Welcome, everyone. Today we'll discuss heart failure from the perspective of the acute physician. Heart failure is one of the commonest reasons for hospital admission and a condition every clinician must recognize early. During this session, we'll use cases, imaging, and guideline based management to build a practical approach. By the end, you should be able to recognize different presentations, investigate appropriately, and initiate evidence based treatment. The objectives are to understand the epidemiology, classification, diagnosis, and treatment of heart failure. We will also discuss acute pulmonary edema, decompensated heart failure, and the major advances in therapy, including SGLT2 inhibitors. Focus on practical decision making that can be applied immediately on the acute take. Heart failure is a major public health problem. It accounts for a significant proportion of medical admissions and readmissions. Despite therapeutic advances, prognosis remains poor. One teaching pearl is that recurrent admissions often indicate suboptimal optimization of guideline directed therapy or unmet social and community care needs. Consider this first case. Before looking at the diagnosis, ask yourself what features point towards congestion. Previous myocardial infarction is a major clue. Orthopnea and paroxysmal nocturnal dyspnea are classic symptoms of elevated left-sided filling pressures. Think systematically about whether the patient has left, right, or biventricular failure. The examination demonstrates fluid overload. Raised JVP, peripheral edema, and crackles are classic findings. Always assess the whole patient rather than relying on one sign. In older patients, crackles may be absent despite significant heart failure. These are the common symptoms and signs. Dyspnea is the most common symptom. Orthopnea and PND are particularly suggestive. Remember that fatigue and reduced exercise tolerance may be the dominant symptoms, especially in elderly patients. This patient actually demonstrates features of biventricular failure. The pulmonary findings indicate left-sided congestion, while peripheral edema, sacral edema, and elevated JVP indicate right-sided involvement. In practice, many patients have mixed pathology. Now consider the second case. This patient has a recent STEMI and presents severely unwell. Ask yourself whether this is simple heart failure or whether there are features of cardiogenic shock. The history should immediately raise concern about severe LV dysfunction. The observations are worrying. Hypotension, severe tachycardia, hypoxia, and poor peripheral perfusion suggest shock. Teaching pearl. Cold peripheries and altered perfusion often identify shock earlier than blood pressure alone. Review the chest radiograph systematically. Look for cardiomegaly, pulmonary venous congestion, interstitial edema, and alveolar edema. Imaging should always be interpreted alongside the clinical picture. This case represents acute decompensated heart failure with pulmonary edema and cardiogenic shock. It is important to recognize that these terms often overlap rather than being mutually exclusive diagnoses. Heart failure can be classified into systolic dysfunction, diastolic dysfunction, and right-sided failure. Modern classification is increasingly based on ejection fraction because this guides treatment decisions. Ischemic heart disease remains the leading cause of left ventricular systolic dysfunction. Always look for reversible causes such as arrhythmia, valvular disease, alcohol excess, or uncontrolled hypertension. Right-sided heart failure is often secondary to left-sided failure. Pulmonary hypertension and chronic lung disease are other important causes. When assessing right heart failure, always consider the underlying driver. Differentiating right from left heart failure relies on careful bedside examination. JVP assessment remains a valuable skill despite increasing reliance on imaging and biomarkers. Raised JVP is one of the most useful signs of systemic venous congestion. Ensure the patient is positioned correctly. One common pitfall is confusing the carotid pulse with the venous waveform. Peripheral edema, sacral edema, and ascites indicate chronic systemic congestion. Sacral edema is particularly useful in immobile patients. Always assess for hepatomegaly and abdominal distension. These findings reinforce the importance of looking beyond the lungs when assessing heart failure. Congestion can affect multiple organ systems. Clinical examination remains fundamental. Imaging supports but does not replace a good bedside assessment. Always integrate history, examination, and investigations. No single sign or test confirms heart failure in isolation. Investigation should include ECG, blood tests, natriuretic peptides, chest imaging, and echocardiography. BNP and NT-proBNP are particularly useful in excluding heart failure when low. Pulmonary edema and pleural effusions are common radiographic manifestations. Bilateral pleural effusions often suggest chronic congestion. The batwing pattern represents central alveolar edema. It is a classic examination and teaching image that should be recognized immediately. Curly B lines represent interstitial edema and increased lymphatic pressure. They are often an early sign of pulmonary congestion. Echocardiography is the cornerstone investigation. It identifies ejection fraction, chamber size, valvular disease, pulmonary pressures, and alternative diagnoses. Ejection fraction is the percentage of blood ejected from the left ventricle during systole. Modern heart failure classification is based on EF because treatment efficacy varies between groups. Current classifications include HFR-EF with EF 40% or less, HFMR-EF with EF 41 to 49%, and HFPEF with EF 50% or greater. The strongest evidence base exists for HFR-EF. The goals of treatment are symptom control, reduction in hospitalization, and improvement in survival. Successful treatment requires both pharmacological and non-pharmacological interventions. Diuretics are primarily for symptom relief. They reduce congestion but do not improve survival. Always reassess renal function and volume status after initiation. Treating the underlying cause is equally important. Control arrhythmias, optimize blood pressure, manage ischemic heart disease, and address valvular pathology where appropriate. This treatment algorithm should now be viewed through the lens of contemporary guideline-directed therapy. Early initiation and rapid up-titration are encouraged. Modern heart failure management focuses on 4 foundational therapies rather than sequential treatment over many months. The 4 pillars of HFR-EF management are an SGLT2 inhibitor such as dapagliflozin or empagliflozin, an evidence-based beta blocker, an MRA such as spironolactone, and an ARNI such as sacubitril valsartan or alternatively an ACE inhibitor. These therapies improve mortality and reduce hospitalization. Cardiac resynchronization therapy is indicated in selected patients with reduced ejection fraction and electrical dyssynchrony. Appropriate patient selection is critical. Left bundle branch block produces ventricular dyssynchrony and reduced efficiency of contraction. Recognizing LBBB on ECG has important therapeutic implications. CRTP provides pacing therapy to improve synchronization. Patients often experience improved symptoms, exercise tolerance, and quality of life. CRTD combines resynchronization with defibrillation capability. It is particularly valuable in selected patients at high risk of sudden cardiac death. Advanced heart failure management may include device therapy, specialist referral, transplant assessment, or palliative approaches depending on the clinical situation. Early specialist involvement improves outcomes. Thank you for attending. Remember the key principles. Recognize congestion, identify the underlying cause, use echocardiography and natriuretic peptides appropriately, and optimize all 4 pillars of guideline-directed medical therapy. I am happy to take questions.